Amit,
Jeff.
this is really exciting because I've been looking forward to this interview for some time.
Okay, tell me why.
Well, I first heard this speaker at RAUK in Newcastle.
That's right.
In 2023, and she inspired me with her thoughts about how to talk to patients.
And we actually did a little talk about this, and we did a catch-up on RUK 23. We're delighted. We've got Barbara Breebaart joining us in the Block Box. Thank you so much, Barbara, for joining us. Yay!
Thank you for inviting me.
So, for our listeners who have yet had the chance, who haven't met you yet, tell us who you are. We know your name now, but pronounce it correctly for us, and where you work, and tell us the type of things you're interested in.
I'm Barbara Breebaart.
Let's hear you a bit louder.
Barbara Breebaart.
That's
so
better.
the way you say things is very important.
Yeah.
You can
Yes.
hear.
Yeah.
I'm from Antwerp,
Yeah.
and my special interest is soft skills. It's everything to do with how we treat patients, how we look at patients. So everything but putting the block in.
Yeah, and which is possibly more important, or maybe you think maybe more important than how to get the needle next to the nerve.
I'm interested. Why do you call them soft skills? Where did the idea behind because they're really important, right? But where does the term? I know you didn't invent the term, but why is it called soft skills?
That's a very good question. I can guess, but I don't really know. But I think soft skills is because it's something fluent. It is not the same for everybody. I think maybe you see soft skills. Your soft skills can be different than mine.
Yeah.
While a technique like in plane or out of plane is very strict.
Okay.
This is only a guess.
Yeah,
So-
okay. So tell us a bit more about soft skills, because I've noticed you're very observant. You'll walk around, you'll watch interactions between one person and another. You can tell a lot about a person by the way they hold their body, by the way they're posturing. And you caught both Jeff and I out a couple of times by taking a picture and saying, "Why are you standing like that?" So give us a bit of an insight into what it is that drives you and how you use that in your patient interactions.
Well, I believe if you come into the room, your patient has made up his mind within 6 seconds if you're competent, if he can trust you.
6 seconds.
Yeah.
Oh, wow.
Do you know the surgeons, you know their skills. Patients, they don't know their skills.
Right.
So they have to guess based on body language.
Uh-huh.
This is one thing. So it's so important you can give the patient more trust, more warmth, and a sense of safety by just doing things that send competence.
Yeah.
So this is so important.
We can't let that go. So if I'm about to walk into the room to interact with a patient, what should I be presenting within... I'm nervous now. What do I need to present within 6 seconds to get them to trust me?
If I would choose one thing, it would be a genuine smile. This is not a genuine smile. This is a fake. You know the difference between a fake smile and a real smile? So this is a fake smile.
Okay,
Yeah.
make sure the camera can see it. That's fake.
Okay.
Yeah.
Now do a
But
real
if
smile.
if your eye muscles go
Okay.
with it, like
That's
a real one.
Yeah.
Like the
Oh, yeah.
colleague in the hallway you don't
if
like,
this
you
is
say
like
hi.
Botox, so
Hi.
this is not right. And okay.
So,
no.
but
yeah. So
if
smile,
you are,
be genuine.
If you are happy yourself, it's contagious. Your feelings are contagious, and you can transfer them to the patient.
Yeah, because they sense
So,
you're confident, calm, you're in control, because you're happy about this. You're not walking in going, I'm going to look after you today.
Yeah.
But it's not always appropriate to walk in smiling at the patient. Right? There's a fine line. So you've got to, when you greet them, I guess, smile. But what you're saying is don't project that nervous body energy. But is confidence a good thing? Should we walk
Confidence is definitely a good thing, as long as it's not becoming
in?
arrogance.
Is there a fine line between confidence and arrogance?
It depends. I think if you put your
Like,
head
how
more like this,
I have to do that
not
because of my double
smiling.
chin. I need to hide my double chin. So tell me, Sam, when you walk into a room, you should be good posture.
Yeah, but also, in my opinion, also warmth.
Yeah.
Maybe there are
Probably that's
anesthetists
more
who say,
important.
okay, I want to be only competent, I don't need the empathy. Maybe this is also okay.
Have a bad rep, right? People say we do anesthesia because we don't want to talk to patients. That's what that's what people think generally. We know that's not the true for necessarily all of us, because we picked a subspecialty of regional anesthesia because you possess some skills. So competency, warmth, what else? So tell us more. Sorry, I interrupted your flow.
Well, you have your body language, which is one thing, and then secondly, you have the things you say. Of course, you have all these informed consent stuff, but then I have a lot of people who are explaining what they're doing to the patient. It's like, why does the patient care what you're doing? So I try to talk about other stuff, like distraction, about, okay, what is your hobby? What do you like to do? Where would you like to go in your head right now? And not using nocebos. Because nocebo is something negative that's going to happen. It's like, okay, I'm going to sting, 1, 2, 3, then patient expect pain. And it's proven that they will feel more pain because we announce it.
Yeah, that was one of the things I took home from your lecture from a couple of years ago, and I use this now. Instead of saying, I used to say, you're going to feel a sharp sting or a little scratch, I'll just say, I'm going to put some...
But we were taught that. We were taught that. When we sharp scratch, ouchie, ouchie, I've heard all variations of it.
Yeah, it's going to hurt me more than it hurts you. Yeah.
This is because we think we do right by announcing pain, because we don't want to hurt somebody without saying it, because we are nice people.
But you're saying, so we should inform patients that we're going to do something?
No, not necessarily.
So
if you go for your vaccination, you know what's happening, right? If they don't say anything, it's not like, oh, surprise, I'm getting a shot. Sometimes it's clear because of the things you do and the things they see. If you're doing a spinal, then it's necessary to say something.
Okay, so I want to ask you a spinal thing. So I've started using neutral terminology. I'm just placing a cannula or I'm placing a butterfly in the back of your hand. So I'm not telling them how they should feel, but I'm telling them about to do something. But with a spinal, I still hear people say, okay, this is going to sting now. What should we say when we put local anesthetic in the skin?
I just say, I'm going to numb the skin, or I'm going to start.
It's so obvious because it's what you're doing.
Yes, yeah. And so you think
it's as simple as that.
Yeah. I think that's effective. Here, can I share with you a pet peeve of mine? And maybe I'm wrong on this, but it drives me bonkers when trainees are attempting a spinal or an epidural, and they say, hey, what side are you feeling that on? And I'm like, oh my God. Number one, there are fibers that cross over, so maybe that feedback is not so accurate. But number two, you've completely shattered the confidence that that patient has in you by asking that question. Because imagine a surgeon says, hey, do you think I'm in the right spot right now when I'm operating on you? The patient would be like, what? Shouldn't you know this? What do you think about that?
So you answer first, because it's interesting. I've got some thoughts.
I totally agree. This is a semantic language thing. You have words you say, but you also have the reason why you say them, and this is not always necessarily the same. Because if you ask which side do you feel it, the patient has to think, why are you asking, and has to make up something because he doesn't know.
Yes.
So the reason why you say things is not always clear, and then it is an indirect suggestion, and you have to fill it in.
Right.
So it could be negative, as you said.
I see both of your points, but really interestingly, probably the last 6 months to a year, I've had some residents who, these patients are patients that are living with obesity. It's not easy to palpate the midline. So you kind of think you can feel a spinous process, but you can't necessarily do that. And I've heard them push on the back and say, does that feel like it's in the middle of your back to you? Is that harmful? Because they don't know, because you can't feel it. Yes, I know you've got ultrasound, but they're pushing the back, they're like, does that feel in the middle of the back? And patients will sometimes say yes or no, or they say, actually, that feels like it's a bit to the left. The other thing I've heard people do is when they've stuck the needle in, and they're getting that feeling that you don't really want to get, and it doesn't feel right, and if the patient says, oh, that feels a bit weird, I've heard them say, does that feel weird on your left or your right? So that's in response to a symptom, and you still think that's wrong? I think if you're saying, does that feel like it's going on the left, that phrase like a question sounds like, I don't know what the hell I'm doing.
He used the word hurting and harm, so this is different. I think the way you ask, if you ask, can you maybe help you do an optimal procedure by indicating some things I'm going to ask you, then it's a totally different atmosphere than, hey, does it hurt left or right?
I like that. See?
It's like all that, in the framing, language. Isn't it?
Yeah.
It's all in the framing of the question.
If you can help me help you, then you ask them to help you. this is something people really want to do. So this is a kind of mind trick which you do. You
Yeah.
make them feel good because they can help you, but this is an indirect way of making somebody's mind positive.
Semantics, yeah, exactly. So what are some of the other things that are exciting you in this realm?
What else do you do? What else are you passionate about? Do you use hypnosis? Do you use a lot of other scripts before intervention? Tell us what you do.
Well, we started this, me and a colleague, in 2011, and we were trained in medical hypnosis. But I took it more to the communication part, and she took it more to the real hypnosis part. Sometimes I do this, but not so much, because I think only communication is a very good tool on its own. What I'm now very enthusiastic about is the body language part, because this is very narrow in everything that's been described and been studied, and it's so important.
Because it's interesting, right? If I speak to a patient and try to get to take consent to do a procedure X or Y, I've got dichotomous outcomes. They either say yes or no, but more often they'll say yes. If I send my resident or my trainee, my junior, to go and consent for the same procedure that maybe they haven't done as many times as me, or they don't have some confidence, there will be a proportion of patients, a higher proportion of patients that say no. And if I then go back and try and rescue the situation, often patients will say yes. So part of that is the way we communicate.
Partly it's your smile.
It could be my smile, but we obviously project some confidence. So I've had interactions with patients who've said to me in the past, "I trust you." At the end of the consultation, I say, "Are you happy for me to do that?" I say, "Yes, I trust you." So there must be something about the way we convey the information that they find meaningful. But some of these things are subconscious, right? And sometimes and I think the magic is to find out what the secret is so you can teach people that. And so that's what I'm hoping you'll give us some insight into.
The first thing of all is to become conscious of your own body language, and to learn how to read body language and to look at people. What are the small signs? Which positions is open? What is closed? But it's not magic. It's like if you don't agree with something, you can learn body language, but it will always come out somewhere. It's subconscious. So
Right.
even people who are trained very well, like politics, they always show their
have a
real
tell,
feelings somewhere
right?
in a leg or in a finger or somewhere small. So, but for your question, you have to start with becoming conscious. What position do you have? How do you look? Do you make eye contact, yes or no? How does the patient react?
When I see a patient in our pre-op block area, they're on a stretcher. They're already changed in their gown and they're on a stretcher. And there's usually a couple of chairs beside the stretcher for the family members, and I'll come in and I like to sit down when I'm doing my.
You're not towering over the patient.
Yeah, exactly. Consent. It just feels more comfortable, a better way to establish a connection with someone. Does that ring true to you? Or
Yes, absolutely. It's called mirroring. We have like mirror neurons, and this is something we do when we are a baby. If a mother feeds a baby, the baby opens the mouth, and the mother also opens the mouth. Or if somebody starts yawning, other persons will start yawning too. So
Isn't that
people
weird?
mirror each other all the time, and this is a way for us to make connection with our body language. So if you get at the same level of your patient, you're mirroring, and you get a better connection and a better understanding, and they also get a feeling, well, they take the time for me to sit down and they are at my level. But if you mirror, you say, hey, I'm willing to stand in your shoes and to feel how you feel.
It's
This
interesting
connects.
that backfired on me once. I went into a patient room to consent them preoperatively, and there was no chair. Thought, I don't want to stand up, so I'll squat. I'll get on my haunches. And the conversation took a little bit longer than I expected. At the end of the conversation, I thought, I can't feel my legs. And I think I gave myself some kind of bilateral sciatic nerve paresis. And I got up and I had to stumble out of the room. And whatever positive I had with my body language, I undid after that. Okay, so that's really interesting. Now, I have had some patients who are so fearful of the act of going off to sleep, of actually drifting off to sleep. So you get the cannula in, that's okay. You get them fully monitored, that's okay. But that moment of going off to sleep, they're petrified of. What are the strategies and techniques we can use to smooth that I know it's a regional anesthesia podcast, but there are cases when we give general anesthetic or start sedation. So how can we make that experience pleasant for our patients?
My normal procedure is I ask the people, where would you rather be at this moment? And then most of the time they come up with a place. And then you start asking questions, and you go over all all sensories, like how does it smell there, what do you see, and then you get them to another place in their head, and then most of the time it goes very smoothly.
So are you doing this whilst you're administering the medication?
Yeah.
And do you give them a precursor or a warning as to what that sensation might be? Because you don't tell them anything.
No.
So they're just talking, telling a story,
Yeah.
and that active process of getting their brain to think about something else is that's interesting. Do you use strategies like that?
I do. I as I'm getting them off to sleep, I'll say, like, okay, where are we going to go on this trip, on this dream? Choose anywhere you want to go. And then usually it's like a beach location.
Yeah.
8 times out of 10. So I'll say, all right, you're on the beach, your feet are in the sand, there's waves lapping at the shore, palm trees are swaying in the breeze.
I was feeling so relaxed. I was
the cabana boy is bringing you a drink with an umbrella in it and those sort of things. So I'm also a big toucher, and maybe that's not.
That's not a bumper sticker you want to have.
No. But like I can't help it. I just the way I saw all.
You mean, but appropriate.
Off and shoulder. I'll say, okay, I've got you. You know, this is we're going to take good care of you today.
I feel safe now. You see that? I feel safe.
Yeah.
I feel reassured.
I'll give these sort of reassuring words as they're drifting off. So the last thing they've heard is me saying, I have you.
Because there are some patients who have this vision that we go off to sleep, we put them to sleep, and then they're left on their own, and no one's going to be with them. And it's this fear that no one's going to be there for them, and maybe that last thing, hearing that they're safe afterwards. I think it's powerful communication. I had one patient who had multiple operations, and every time they went off to sleep it was breast cancer surgery, she burst into tears, and every time she woke up she burst into tears. So I had spoken to Gehan van Geffen in Toronto, and he told me about some of these strategies. I hadn't read anything. I tried to use some of those strategies when I was inducing anesthesia in her, and I got her to talk about a beach holiday. And I got her to, and he told me something about, as you're injecting, can you feel the sun on your forearm? So just switching the language, and she was going to say, oh, it feels something, but I kind of told her that it might be the sun. She went off to sleep with a smile on her face, and she woke up crying. I thought, oh no, I messed up. She was crying with joy that she wasn't upset. So I think we really need to understand more about this world. If we wanted to go and look and find out more, where would you direct us?
I think the book from Elvira Lang, it's like this thick. You can read it in a weekend, and you can just start doing the stuff in your own hospital. You can also follow her course, but reading the book is so worthy. I think.
That's cool. We'll put a link to that in the show notes. Yeah,
absolutely.
As well. Any other tips or tactics that you use to put patients at ease and to?
Well, we also have these VR hypnotic classes. It's not suitable for everybody because some people get nauseous from it. We use this as well. And some patients also sometimes just need chit-chat.
Yeah.
You have patients like they need relaxation and you lower your voice. But you also have patients who just want to tell about their day or about their job. I had this one guy, so a very obese guy with a long beard full of tattoos, and I asked him, hey, what do you do as a job? Oh, I work in a harbor, I drive this big truck. And then I asked, oh, okay, what do you do as a hobby? And he said, well, I sing musicals. I said, okay, I'm interested. What is your favorite musical? And then I don't remember which one. And I was putting in an axillary.
Little Mermaid.
And I thought, would you like to sing it for me? So I put in the axillary, and this big truck driver sang for me a musical. So this is, if you're really interested in your patient and really listen.
Can you imagine
there are
that
so
scene?
many things
This
coming
big
out.
guy with a beard and tattoos.
If I would have come
singing.
in and say, hey, I'm doctor this and that, I'm going to numb your skin, I'm going to put an IV, and blah, 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 nothing would have happened.
Yeah.
It's just be interested in your patient as a human.
Oh.
Also.
And I think that's something that gets lost sometimes on medical students when they're asking the question like, why did you go into anesthesia? Don't you like patients?
Yeah.
I've had that question, right? And I
Yeah,
say, actually, it's the opposite. I love patients. I've got 6 minutes
Yeah.
to make a connection, maybe 6 seconds actually, but I got a short time to make a connection, and that makes it much more valuable in terms of what I have to do. I don't have weeks and weeks and
It is
multiple
so
visits.
satisfying if
Yeah.
you get patients who had a terrible experience and they come to you and they said, oh, this was so much better. It's so satisfying.
Yeah.
Even
Yeah.
if it's only for 5 minutes.
Yeah.
Yeah.
Yeah. That's a
I
good
think
day.
so.
I go home feeling good that day.
Barbara, you know that we always like to close out the podcast or start the podcast with a joke. Did you bring a joke with
Yes,
you?
I did bring a joke.
Okay.
So, why did the blonde stare at the orange juice for 2 hours?
Why did the blonde stare at the orange juice for just 2 hours? Now, just frame a reference. If you're not watching a video podcast, Barbara is blonde. Okay, just to clarify. I know why, but I want you to say the punchline.
Because it said concentrate.
Yeah. Very good. Very good. Yeah. But Barbara,
Yeah.
you've given us so much to think about, and every time I speak to Barbara, outside a block box, I'm always nervous because I know she's watching my micro expressions. I'm thinking, what am I going to say? What am I channeling? But honestly, you've given us so much food for thought, and I think there's a lot more to this than we realise. So I think at some stage we're going to have to get you on the podcast, and we'll do a whole episode talking about non-verbal communication. That's something that would excite you.
Marvelous.
Thank you so much for
Thank
spending the
you.
time with us.
Yeah,
It was
thank you,
really
Barbara.
wonderful.
Thank you.
Thank you.